Welcome everyone to my presentation on rheumatoid arthritis. Today, I will be discussing the symptoms and diagnosis, the underlying physiology and pathology, treatment options, and some research. Rheumatoid refers to conditions related to rheumatoid arthritis, a chronic autoimmune disease that attacks joint tissues, causing inflammation, pain, and deformity. The term originates from rheumatism, historically used for joint-related disorders. Today, rheumatoid specifically pertains to RA in medical terminology. Fun fact, the term rheumatology originates from the Greek word rheuma, meaning that which flows as a river or stream. Combine with the suffix ology, and you get rheumatology, the study of a flow or a current. Rheumatoid arthritis is classified as an autoimmune disorder, reflecting the body's immune system malfunction. RA is a systemic autoimmune disease characterized by inflammatory arthritis and extra-articular involvement. It is a chronic inflammatory disorder caused in many cases by the interaction between genes and environmental factors, including tobacco, that primarily involve the synovial joints. The condition leads to inflammation of the synovium, causing pain and swelling in the affected joints. Joint inflammation over time leads to the destruction of the joint with loss of cartilage and bone erosion. If untreated, rheumatoid arthritis can result in permanent joint damage and deformity. It is a progressive disease with morbidity and increased mortality. Rheumatoid arthritis commonly begins in middle age, impacting individuals significantly during this life stage. RA is more prevalent in women than men, highlighting the need for gender-focused research and treatment. Understanding the demographics aids in effectively targeting research and treatment efforts for RA. The worldwide prevalence of RA in the Global Burden of Disease 2010 study is about 0.24%. As I mentioned, RA is more prevalent in women compared to men, with a lifetime risk of 3.6% in women compared to 1.7% in men. There was an increase in the global period prevalence of 9.75% over the time period of 1980 to 2019. Among modifiable risk factors, cigarette smoking has the strongest association with RA. Diet and nutrition have been shown to play a significant role as environmental triggers for RA. The typical Western diet that is rich, high in caloric content, and low in fiber increases the risk of RA. Consumption of long-chain omega-3 polyunsaturated fatty acids is associated with a reduced risk of RA. Obesity is another well-established risk factor for RA. There is a 30% increase in the risk of RA for patients with a BMI of greater than 30, and a 15% increased risk for those with a BMI 25 to 29.9. This graph shows you the male and female prevalence by age. As you can see, if you choose, like for example, 55 to 59 right here, there is a much greater prevalence for females at every single age. There will also be an increase in RA as our population grows. And a quick stat, 71 in every 10,000 American people are diagnosed with RA every year. 1.5 million Americans currently have RA, and as I mentioned, there's a 2% risk in men and a 4% risk in women. RA generally starts in women between the ages of 30 and 60 and is slightly later for men. There are genetic risk factors. HLA-DR4 and HLA-DR1 are specific alleles of the human leukocyte antigen class II gene. HLA-DR4 in particular is strongly associated with RA and is found in a significant proportion of patients. It plays a role in antigen presentation and immune system regulation, and leading to an increased risk in autoimmunity. The most well-established environmental trigger for RA is smoking. It increases citrullination in proteins, which can trigger an autoimmune response, particularly in genetically susceptible individuals. And certain infections have been linked to RA. These infections may contribute to immune dysregulation and trigger autoimmune responses. Women are more likely to develop RA than men, suggesting a hormonal component. As I mentioned, increased adipose tissue contributes to chronic low-grade inflammation, which is why obesity is a risk. Diets high in processed food and red meat have been associated with increased risk in RA, while anti-inflammatory diets may be protective, and chronic stress can influence immune function, potentially contributing to RA onset or flares. Patients with rheumatoid arthritis experience numerous health challenges beyond joint pain, including chronic fatigue and systemic inflammation. There is a significant increased risk of cardiovascular disease in patients with RA, necessitating preventative care. Rheumatoid arthritis can lead to a reduced life expectancy, highlighting the need for comprehensive management and care. Okay, our symptoms and diagnosis. The acute indicators for RA are joint swelling, often affecting the fingers and toes. Patients with RA experience tenderness and pain in their joints, which can hinder their daily activities. Acute symptoms can flare up suddenly, causing distress and significant discomfort for patients. Chronic conditions often lead to persistent joint stiffness, which can significantly impact mobility and quality of life. Fatigue is a common chronic indicator that can affect the daily activities, making it essential to recognize and address. Systemic symptoms such as fever and weight loss are crucial indicators for underlying chronic conditions and require attention. Physical examinations are essential for assessing joint health and identifying signs of inflammation in RA. Gathering a thorough patient history helps in understanding symptoms, previous conditions, and treatment responses related to arthritis. Imaging is also another diagnostic method, such as X-rays and MRIs. They are crucial for visualizing joint damage and monitoring the progression of RA. This is swan neck deformity, as seen in an X-ray here. And then blood tests are also a critical way to detect specific antibodies and inflammatory markers, aiding in the accurate diagnosis of RA. Blood tests we use are rheumatoid factor, RF, an autoantibody present in 70 to 80% of RA patients, but not specific to RA, as it can be found in other autoimmune diseases and even in healthy individuals. The anticyclic citrullonated peptide, anti-CCP, the erythrocyte sedimentation rate, or ESR, the C-reactive protein, CRP, complete blood count, CBC, and the HLA-DR4 genetic testing. This is not a diagnostic test, but can indicate a genetic predisposition to RA. This is the cumulative incidence of rheumatoid arthritis for four categories of baseline level rheumatoid factor. So as you can see, it increases dramatically as the patients get older. This blue line is a rheumatoid factor greater than 100. Okay, underlying physiology and pathology. RA is an autoimmune inflammatory disease characterized by the destruction of the synovial joints due to chronic immune activation. The biochemical mechanisms involve immune system dysregulation, cytokine overproduction, and oxidative stress, leading to joint inflammation and degradation. RA is triggered by antigen-presenting cells, APCs, that activate CD4 plus T helper cells. This leads to overproduction of pro-inflammatory cytokines, recruitment of B cells, which produce RF and anti-citrullonated protein antibodies, and then chronic immune stimulation within the synovial tissue, causing persistent inflammation. The disease process begins when APCs such as dendritic cells and macrophages present autoantigens to naive CD4 plus T helper cells in the lymphoid tissues. These autoantigens are thought to include citrullinated proteins, which result from citrullination, a process where arginine residues in proteins are converted into citrulline by peptidyl arginine deaminases. A key feature of RA is citrullination, as I mentioned, a post-translational modification of proteins mediated by PADs. The process where normal part of the protein, arginine, is changed into citrulline by an enzyme called peptidyl arginine deaminase, again, just reiterating. Normally, this happens naturally in the body, but in RA, too many proteins become citrullinated. The immune system doesn't recognize these altered proteins as normal, so it treats them like foreign invaders and starts attacking them. This leads to the formation of anti-citrullinated protein antibodies, ACPAs, which are highly specific for RA and immune complex deposition, stimulating inflammation and joint damage. This ongoing mistake by the immune system is what leads to chronic joint inflammation and damage in rheumatoid arthritis. This is just a visual understanding. And then another possible reason RA develops is something called molecular mimicry. This happens when a virus or bacteria has proteins that look very similar to the body's own proteins. If the immune system fights off an infection and learns to attack these microbial proteins, it might start attacking similar-looking body proteins by mistake. This could be another reason why the immune system starts attacking the joints in RA. Inflammatory signaling pathways. The NF-κB nuclear factor kappa light chain enhancer of activated B cells pathway is central to RA inflammation. The TNF-alpha and IL-1 activate NF-κB, leading to transcription of inflammatory genes. This promotes matrix metalloproteinases, MMPs, that degrade joint cartilage. And then other key pathways include the JAK-STAT signaling pathway, which drives synovial hyperplasia and pannus formation, and the MAPK pathway, which regulates inflammatory cytokine production. Because I don't have time to discuss all three of them, I'm going to focus in the forthcoming slides on the NF-κB pathway and the JAK-STAT pathway. RA is associated with increased oxidative stress, leading to reactive oxygen species, ROS production, damaging the synovial cells, mitochondrial dysfunction, further amplifying inflammation, and an increased lipid peroxidation, exacerbating joint destruction. Okay, what is NF-κB? NF-κB is a protein complex that acts like a switch for the immune system. When it's turned on, it activates genes that produce inflammatory molecules. This is helpful when fighting infections, but in RA, the NF-κB pathway is overactive, leading to chronic inflammation and joint destruction. So this is a visual of the pathway that I will explain now in further detail. So the cytokines like TNF-alpha or IL-1 bind to their receptors on immune cells in the joint. This activates an enzyme complex called IKK, which is the IKB kinase. IKK phosphorylates IKB, marking it for destruction. Once IKB is degraded, the NF-κB is released and moves into the cell nucleus. Inside the nucleus, NF-κB activates genes that produce inflammatory molecules like cytokines, chemokines, and enzymes. Here is a visual of that pathway again, if you want to take a closer look. This is a list of the cytokines. There's a lot of different ones. IL-1, IL-6 are very popular. TNF-alpha is very popular, or is seen frequently. This is the source of the cytokine, and these are the specific receptors. So again, NF-κB is always active in RA and leads to more inflammation, which keeps the immune system in attack mode, cartilage destruction due to an increased MMP production, which breaks down joint cartilage, bone erosion stimulated by osteoclasts, leading to bone loss, and pannus formation, the thickening of synovial tissue, worsening joint damage. And then here is an image of a joint. Here's the normal joint where you have our joint space, cartilage, synovial membrane, bone. Here you have rheumatoid arthritis, the osteoclasts eating away at the bone. We have overproduction of macrophage, cytokine productions, a heavy immune response of T cells and B cells. We have an overproduction of the synovial cells and another osteoclast down here, eroding the bone. The JAK-STAT pathway. So JAK-STAT is the Janus kinase signal transducer and activator of transcription pathway. It's cytokine interaction. The pro-inflammatory cytokines, such as interleukins and interferons, attach to their corresponding receptor on the cell surface. The interaction triggers the activation of associated JAKs like JAK1, JAK2, JAK3, or type 2, resulting in their phosphorylation. The phosphorylated JAKs then recruit and phosphorylate STAT proteins. Once activated, the STAT proteins dimerize and move into the nucleus, where they commence the transcription of genes that play roles in inflammation and immune responses. Here is a diagram of the JAK-STAT pathway. You can see IL-6 binding to the receptor, GPC130. These two come together and dimerize. JAK3 is activated, which then phosphorylates STAT3, which moves into the nucleus. These are two great videos on YouTube if you're interested in watching more on the JAK-STAT signaling pathway. Excessive activation of JAK-STAT pathway prolongs inflammation leading to joint destruction. STAT3 overactivation drives fibroblast-like synoviocytes, FLS, proliferation, which thickens the synovial membrane, forming a pannus that invades cartilage and bone. Angiogenesis supplies nutrients to the inflamed synovium, sustaining chronic inflammation. Our treatment options. The current pharmacology consists of nonsteroidal anti-inflammatory drugs, NSAIDs, which are commonly used to alleviate pain and reduce inflammation. Examples would be Motrin or naproxen. Glucocorticoids are the next step. They offer rapid anti-inflammatory effects and can slow joint damage. Examples are prednisone and methylprednisone. And then disease-modifying anti-rheumatic drugs are the key players for rheumatoid arthritis. DMARDs help slow the progression of rheumatoid arthritis and prevent joint damage over time. So there's a few different kinds of DMARDs. There's the conventional synthetic DMARDs. Methotrexate is often the first line of treatment due to its efficacy and safety profile. There are biologic DMARDs, which are the inhibitors. So you have the tumor necrosis factor TNF inhibitors. You have interleukin inhibitors like tocilizumab and anakinra. And then you have the B-cell depleting agents, rituximab, and T-cell co-stimulation modulators like abatacept. Since the NF-κB pathway is a key driver in RA inflammation, many RA drugs try to block this pathway. TNF-alpha inhibitors prevent the NF-κB activation. JAK inhibitors reduce cytokine signaling, indirectly lowering NF-κB activity. And natural inhibitors, like curcumin from turmeric, have been studied for their ability to block the NF-κB pathway. Utilizing multiple DMARDs concurrently can enhance therapeutic effects, especially in patients with an inadequate response to monotherapy. Example is methotrexate combined with hydroxychloroquine and sulfasalazine, known as triple therapy. Since the JAK-STAT plays a crucial role in RA, JAK inhibitors have been developed as targeted therapies to block this pathway. These drugs help reduce inflammation, slow joint damage, and improve symptoms. Treat to target is another strategy, aiming for specific goals such as remission or low disease activity with regular assessments and therapy adjustments to achieve these targets. The therapeutic effectiveness, so measuring improvement in symptoms is crucial for evaluating the effectiveness of rheumatoid arthritis therapies. Assessing joint function allows for a better understanding of how these therapies impact the mobility and daily activities. Overall quality of life measurements help capture the holistic impact of RA therapies on patients, and monitoring potential side effects is essential to ensure patient safety during RA therapy assessment. Treatments are crucial for managing RA and improving the patient's quality of life. While effective, treatments can lead to potential toxicities that may adversely affect patients' health. It's essential to balance the benefits of therapy against the risks of adverse effects to ensure patient safety. Current problems to address. Ensuring consistent treatment adherence is vital for effective RA management and improving patient outcomes. Access to healthcare remains a significant barrier for patients, impacting their ability to receive necessary treatments. For example, DMARDs are very, very expensive, and this does provide a huge barrier for patient access. Addressing psychosocial factors is crucial for improving the quality of life for individuals living with chronic illness and chronic pain. There was a recent study published in RMD that found that inflammatory activity associated with rheumatoid arthritis is linked to specific cognitive impairments. I thought this was really important and worth mentioning. The study also elucidates that chronic pain, persistent inflammation, and autoimmune processes associated with RA can contribute to mental health issues such as anxiety and depression. This is worth noting and worth mentioning whenever we're discussing the need for more research. Factors like obesity and prolonged inflammation were also associated with higher risk of cognitive deficits among RA patients. Proposals for new strategies. Research can focus on developing personalized medicine strategies tailored to individual patients for more effective treatment. Exploring the genetic underpinnings of rheumatoid arthritis can lead to better understanding the targeted therapies. Developing innovative therapies, therapeutic modalities, can help reduce inflammation and repair joint damage effectively. Emerging clinical and preclinical studies play a vital role in advancing our understanding of RA. These studies are essential for developing more effective treatments for rheumatoid arthritis and improving patient outcomes. It's crucial for healthcare professionals to stay informed about the latest clinical advancements and research development. This is another study that I won't mention because I don't have too much time, but if you're interested, please check it out. In conclusion, rheumatoid arthritis is a complex disease requiring a deep understanding of its biological and clinical aspects. A wide range of symptoms and various treatment options exist, highlighting the need for tailored patient care. Continuing research is crucial for enhancing patient outcomes and overcoming challenges associated with rheumatoid arthritis. I hope you enjoyed this presentation on rheumatoid arthritis. Thank you so much.